about the apical periodontitis. Periodontal, the periapical tissue, it is just the tissue beneath the foramen, the dentino-cemental junction, the apical foramen. For a normal, it's asymptomatic, and tooth respond normally to percussion and palpation test. Radiographically, there is an intact lamina dura. Periodontal ligament space all around the tooth is uniform, even with the root apex. In periodontitis, this is a disease in the periodontal area. There is an inflammation in the periodontium. When it is located exactly around the apical area of a tooth, just at the periapical tissue, it is called apical periodontitis. And this also can be subclassified to asymptomatic and symptomatic apical periodontitis. For the apical tissue, anatomically and histologically, the periradicular tissue consists of three types of tissues: the cementum, the periodontal ligament, and the alveolar bone. The cementum itself is a unique word. We have three types of cementums. We have a cellular extrinsic fiber, we have cellular mixed stratified in the middle third, we have cellular intrinsic fiber exactly at the apical area. And as you know, the extrinsic fiber, they are secreted by the cementoplast and the Sharpie's fiber. Okay, they are the end of Sharpie's fiber, which are secreted by the fibroblast partially and partially by cementoplast. And the intrinsic fiber, these fibers of the cementum, they are arranged parallel with the cementum surface, okay, and exclusively they are secreted by the cementoplast. In acellular, which means that there is no cell, no cementocyte, they are just densely packed extrinsic fiber. While the cellular intrinsic, they contain cementocyte. And the cellular mixed stratified, they are a mix of both, and they are arranged alternatively. And this is suppose you know. Okay. There are many growth factors in that region. We have the insulin-like growth factor, we have fibroblast growth factor, we have epidermic growth factor, we have bone morphogenic protein, and we have transforming growth factor, platelet driving growth factors. All these are present. They are present in the cementum matrix. They are released under certain conditions, okay, associated with the activity of the cementoplast in proliferation, migration, differentiation during cementum wound healing. So the periodontal ligament is soft, specialized connective tissue. It connects the cementum to the alveolar bone. The periodontal ligament, it's a heterogeneous cell population and extracellular matrix. The cells in the periodontal ligaments are osteoblast, osteoclast, fibroblast, epithelial cell rest of malaces, macrophages, cementoplast, undifferentiated mesenchymal cell, stem cell. Okay. The extracellular matrix of the periodontal ligament consists of collagen fiber, fibronectin, elastin, other collagenous protein, and protoglycan. All of these are present within cementums. In fibers, in the extracellular matrix, we have this. Okay, in the periodontal ligament, the cells are everything. Some are related to the bone, some are related to the cementum, and some are precursors, like the undifferentiated mesenchymal. The alveolar bone, if I want to define the alveolar bone, okay, in the maxilla or in the mandible, both are that part of the jaw that house the socket of the teeth. It has an outer cortical plate and a central spongy bone or cancellous bone. The bone that line the socket, okay, the bone matrix, again they contain the growth factors that we've mentioned before. These growth factors are really essential for the osteoclast, for the progenitor cell proliferation, which means that they will be precursors for adult cell formation. They are important for migration, for differentiation of the bone wound healing. So the response of the periradicular tissue to various energy is similar to the response of the connective tissue in all the body. It is the same. Again, they have inflammatory reaction that is regulated and guided by the immunity, if it is innate immunity or adaptive immunity. The pathological changes in the periapical tissue in apical periodontitis, they are not directed by the microbes themselves. They are directed by the toxins that produced by these microbes. Okay, the noxious metabolic byproducts of the bacteria. Okay, disintegrated pulp tissue in the root canal system. These irritants, these toxins, the noxious one, they are able to stimulate the innate and the adaptive immunity response. They can activate the nonantigenic pathway, or they serve as antigen to activate the adaptive response. So what we really have in the inflammation at that region, we will have change in the microvasculature, the transmigration of the blood-borne cells, plasma protein out of the blood circulation in the tissue space. Okay, this activation, it will cause activation of the sensory nerve, the endothelial tissue, the mast cell, the platelet, the fibroblast, the neutrophil, microphage, dendritic cell, innate adaptive immune response, immunoglobulin, the inflammatory mediators, and the pro-inflammatory cytokine, chemokine, all the inflammatory response in that region, it will be involved. And as I mentioned before, there are many macrophages, there are many inflammatory factors at the periapical region. And here, if somebody is really interested, he can understand a lot from this picture. Unfortunately, the bacterial biofilm that is there in the root canal system with the necrotic pulp, they are protected by the host defense and the antibiotic therapy because of lack of blood circulation in the root canal system. So, as we know that the blood chamber is limited, okay, so any inflammation in that region against the host defense mechanism of the human being and the antibiotic therapy, okay, all of these consequently will make the wound healing in the periradicular tissue is futile, because bacterial toxin and noxious metabolic byproduct in the root canal continuously will be accessed to the periapical area, irritating the periapical tissue, i.e. to make it more close to you, because the chamber of the pulp is limited by the dentine. Okay, there is no more space. When we have such an inflammation, there is no other way for that inflammation or for that irritant to escape. It's only the apical foramen. It goes where? To the periapical tissue and causing inflammation. So because of this, I can say that the periodontitis really is a dynamic interaction between the microbial insult to the pulp and the host defense mechanism. Okay, it's a balance like when host defense mechanism is less, so the interaction of the microbial toxin will dominate, and so on. From where it will comes out, the seepage is the to where? To the periapical tissue. So, does the normal periodontal health have bacteria? Yes, they have bacteria, invasion to the gingival tissue, but they are in a small number of infiltrated inflammatory cell. So a clearness of this bacteria by brushing, by preserving the health of the gingival tissue, everything can be subsided. But some breach in epithelial barrier function due to some immunological problems, chemical, physical trauma like smoking, alcohol. So this will increase the pathogens in the dental plaque. All the poor oral hygiene, okay, with the bacterial can increase the bacterial invasion in the periodontal area and can cause periodontitis, increase in the inflammatory infiltration, inadequate immune response of the patient. This will cause persisting of infection and it will cause chronic inflammation. That is in periodontitis. So either it comes from the gum here, as I mentioned, or it comes from an inflammation inside the pulp, and that seepage foramen, it can cause apical periodontitis. For the bacterial biofilm, it's a complex root canal system. It is inside the root canal system, even if we clean the root canal system by using antiseptic irrigation, instrumentation, intracanal medication, all these conventional methods, okay, all what we do, we eliminate them, but we cannot be sure that we removed them. Okay, so in such a periapical periodontitis, root canal is a treatment because we reduce the causative factor, we remove the pulp, we eliminate the microbes, and that is why I cannot say that in root canal I will eliminate all the biofilm, but if I am sure of the apical seal, that will prevent these microbes, toxin to invade the apical area of the tooth. So what I am doing in root canal system, I am eliminating, okay, these microbes, and then I am preventing their toxins by the filling material. Root canal system, if it is adequately sealed, so I will protect the coronal microleakage, I will protect the periradical tissue, okay, and then this periradicular tissue, if the root canal was succeeded, then it is able to be repaired and generated because I have all the type of the cells that can help me in do that. But if there is the post-epic, if there is some persisting microbial biofilm are left, or the seal of the root canal is not effective, elimination of the microbes. If I have a hazy filling material, that means that the periapical periodontitis be persisted. So the apical inflammation in the periapical tissue, it's just a reaction of the irritants that comes out from the root canal system. Okay, how I can manifest that? By vasodilatation of the blood vessels and increasing in the vascular permeability and the presence of the exudates. That's the apical infection. And maybe it's due to a physical presence of pathogenic microorganism in the periapical tissue that will produce tissue damage. There are some infection without inflammation. Maybe it happens in immunocompressive patients. It's an inflammation without infection, like in case of myocardial infarction, cerebral infarction, okay, physical and chemical injury. Some physical or chemical injury also can cause inflammation without infection. One of the physical problems is the bruxism. Can bruxism cause a periapical? Yes, it can cause. Yeah. Yes. For the symptomatic apical periodontitis, it's the tooth already is having apical periodontitis as usual, and the patient will come to you, okay, complaining from painless on biting, and on your diagnosis you will check that on percussion the tooth is painful. Okay, so that is a result from a mechanical allodynia or hyperplagesia. For mechanical allodynia, which means that during the action it will be sensitive and there will be increase in the response of pain. As a symptoms in apical periodontitis, it's a painful inflammation of the periodontium, maybe a result of trauma or irritation or infection, okay, through a root canal. So regardless if the pulp is vital or non-vital, it will produce some clinical symptoms. One of them, as I mentioned, is pain on biting, on eating, on chewing, and during percussion. So if the tooth is normal, check for the abnormal occlusal contact, okay, maybe a high spot in opposing tooth, okay, or maybe a bruxism, or maybe, yes, an inserted restoration extend beyond the occlusal plane, which means a high spot side, or maybe the same tooth is restored and that restoration is high. So the patient will come to you complaining of pain on biting. Just remove the cause and everything will be subside. Such a high spot may proceed not only to cause inflammation of the pulp, maybe the tooth will end up to be treated with a root canal. In non-vital tooth, if the tooth was non-vital, then you should think about the pulpal disease. Okay, maybe it started with pulpitis, acute to be chronic, and then it was preceded, or some iatrogenic cause. As I said, pain on tenderness, okay, and pain and tenderness of the tooth, and the patient will feel pain on biting or on chewing. Sorry. On diagnosis, we will notice that there is pain on percussion. Radiographically, it is not necessary that there is some periapical bone destruction. Not necessary. Okay, in acute case, it will not show anything. Though there you will find some widening in the apical periodontal ligament. I mean, lamina dura will be wide, okay, maybe there will be some loss of the apical lamina dura of the involved tooth, which means it will not be attached to the apex. If it was vital, just remove the cause. If the tooth was not vital, then you should do a root canal. What will be the result? It depends on the dynamic interaction, again, between the host and the microbial insult. Okay, so the acute periapical periodontitis may be due to restoration of normal periapical tissue if irritants are immediately eliminated by root canal, which means that everything can be turned to normal. There will not be stain. The periapical periodontitis will disappear from the first visit of root canal treatment. Okay. Abscess formation may be expected if there is a massive invasion of periapical tissue by highly pyogenic bacteria, which means that the toxin of bacteria, if they were strong, you will end up to an abscess. Or it will be a chronic periapical inflammation if the irritant continues. Now, for apical abscess, acute apical abscess, it is a localized diffuse liquefaction lesion of pulpal origin that destroy the periradicular tissue and cause severe inflammatory response to the microbial and non-bacterial irritant from the necrotic pulp. As we said, if the pulpitis is already neglected, it will be a necrotic tissue. So that necrotic tissue, it will end up to a periapical problem, periapical infection. So it's a focal localized or collection of purulent exudate in the tissue of an organ. So the same is here. The battle will be between the highly virulent pathogen and an army of neutrophil leukocytes. Mostly it looks like that clinically, or a swollen face, or maybe a periapical lesion swelling just exactly at the apex region. So it is invasion of combination of specific pyogenic bacteria in the inflamed periapical. Signs and symptoms: there will be rapid onset and spontaneous pain. Clinically, the tooth with acute apical abscess formation have symptoms like pain on biting and on percussion. The periapical area of the involved tooth, if you press on the top of the gingiva with your finger, the patient will feel pain. So it's painful, tender on palpation. But you should know where to press. Okay? There is no swelling. Even if there is no swelling, okay, maybe there will be no swelling in the gum. It's still the abscess is there, confined in the bone. Then by pressing, the patient will feel pain, so you will know. And my advice, just to send for the x-ray to see. Sometimes the patient will have some elevated temperature, malaise, leukocytosis, because it's an infection. Okay. Will the tooth produce stimuli? Yes, on electrical and thermal stimulation. Maybe it will produce some response. They are the most important thing, that they are painful on percussion and palpation. Palpation, as I said, by your finger. Radiographically, it's variable. Either you have no change periapically, or maybe you will have a very obvious radiolucence lesion. Mostly, if the tooth is already was carious and got pulpitis that proceed from acute to chronic, and there is a continuous drain of the purulent fluid through the caries inside the oral cavity, you will not see radiolucency, okay? But then from your diagnosis, you know that there was a drain for that abscess and the tooth root canal. The diagnosis, there is lack of vitality test response, as the necrotic pulp does. Maybe on rare occasion, maybe the tooth will be responsive if you have more than one canal. For example, discoloration of the tooth, yes, in later stages, it will be grayish in color. Is there any response to electric pulses? Why? Because there is a fluid and gases, and those fluids, they will expand and they will press and they will cause pain. The treatment is drainage, and to control some systemic reaction, you prescribe some analgesia to reduce. Antibiotic treatment is needed. There is something also, we call it Phoenix abscess. It's a localized abscess. Again, it's the same thing. Acute inflammatory reaction superimpose an existing asymptomatic apical periodontitis. Okay? It is caused by noxious stimulus from a disease pulp that cause acute inflammatory response, and due to the lowering of the body defense mechanism, okay, due to the influx from the root canal itself, it will cause some Phoenix abscess, which means that yes, it comes after it is a superimpose over the active inflammatory symptoms. Inflammation progress, the tooth gets alleviated from its socket and becomes sensitive. On diagnosis, you will see that it's already alleviated from its socket and it will be sensitive. The mucosa over the radicular area may be appear red or swollen. Check the gum always clinically, not only depending on the percussion, also check the gum. Okay. On X-ray, there will be a well-defined periradicular lesion widening in the periodontal ligament space. The elevation of the tooth from the occlusal plane is due to the pressure at the apical region, so it alleviates the tooth a little bit. Diagnosis, definitely there is a lack of response to vitality tests. Okay. Are not eliminated. Okay, which means I have a failure of root canal treatment. Some symptomatic periapical periodontitis may progress to be asymptomatic periodontitis. So it's characterized by persistence of the inflammatory stimuli, adaptation, the host defense mechanism will be adapted to that stimuli, okay? So there will be some repair process, i.e. will be just formation in the apical region of some granulation tissue. Sign is because the drainage is there, so there will be no symptoms, okay? It's only when, for example, if I have a sinus, which means the swelling area that was obvious in the symptomatic, if it opens to the oral cavity, draining of the pus will be through that opening, okay? Then the case will be chronic and there will be no symptoms because there is a drain. Photographically, radiographically, there will be discontinuity of the lamina dura at the apex region. Okay, there will be ill-defined periapical radiolucency, as you see. Sometime for this, in such cases, you can see, sometimes this sinus, as you see the opening in the clinically, sometimes it is located between two teeth. So I cannot know which one is the cause. So we use the gutta perca because there is a bone resorption. So the gutta perca can find its path through the tissue, through the resorbed canal. Okay? So we can introduce the gutta perca in that area to check whether as you see in the photo, whether the 5 is the cause or the 6 is the cause, especially if the upper 5 and upper 6 both are filled with amalgam, or here in case of the lower 6 you can see the swelling and the drain is there exactly from the sulcus. So you can push the gutta perca through that opening and check from where is the cause. So sometimes if it is accumulation of granulation tissue, it's a granuloma. While if there is such a drain and a pus, so it is chronic apical periodontitis. What's a granuloma really? It's focal area, and remember, it happens because the case was acute, then there was a continuous stimuli by the toxin of the bacteria, the root canal treatment failed to clean all the diseased tissue, and such a continuous stimuli, the defense mechanism of the body got used to it, so the patient does not feel anything. Okay, so the healing, if it occurs, it will occur in a way which is not the correct way. Either there will be accumulation of granulation tissue, okay, and that granulation tissue is inflammatory tissue, so they will have granuloma. Like here, it's a focal area of granulomatous inflammation. Granuloma is relatively, what is it? It's a vascular, a lot of blood in it. Whereas a chronic periapical periodontitis, granuloma is avascular. There is a limitation, no blood vessels, it's just granulation tissue. Okay, while the chronic apical periodontitis will be very vascular. Histologically, some but not all the chronic apical periodontitis lesion show some features of granulomatous infection. I mean, it's a mixed infection. So the term apical granuloma and asymptomatic chronic apical periodontitis should not be used with a sinus. You might end up to even cellulitis. Okay. Development of abscess with intraoral, extraoral drain sinus tracts. Development of serious cellulitis, as I said. Sometime you will end up to extraoral sinus, and that sinus will be obvious from outside, from the cheeks. You have to treat it. Sometimes there is a symptomatic apical periodontitis with a cyst formation, like radicular cyst, chronic apical periodontitis with cyst formation. These things, the details for these things, you should take them in details. I think you have read them in oral pathology, and they will be repeated for you in oral medicine and I am repeating it for you from operative side of view. Okay, so the radicular cyst, which is formed by inflammatory proliferation of epithelial cell rests in the inflamed periodontal ligaments. Okay, it's either a pocket cell which is attached to the apical foramen, as you see here in the blue colored picture, and you can see the arrows that tells you this liquefaction, okay, is an extension from the apical foramen. It's clear here. So it's a pocket cyst, or it's a true cyst which has no attachment. Okay, it is with the periapical area, but it is formed there by itself. And in the other picture, the dark blue regions, it's clear, it shows or it demonstrates the bacterial colony, which are present in the region. The outcomes here, no direct evidence demonstrating whether asymptomatic apical periodontitis with cyst formation, which is either a pocket type or true type, cannot be regressed after non-surgical root canal therapy. Can or cannot be. Sometime with the root canal therapy it will be resolved, sometime you have to extract the tooth. So it is not clear. Unfortunately, apical cyst cannot be diagnosed clinically, can only be diagnosed after surgical biopsy or extraction of the tooth with apical periodontitis. As I mentioned before, you can never guess. Okay? Clinical outcome studies have shown that proper non-surgical root canal therapy only is of beneficial and end up with the healing of the periodontal tissue. It's only in 78% of the cases. So therefore, it's speculated that some cysts, not all, especially the pocket one, which has a relation with the root canal, may show some healing with root therapy only without surgical intervention. The clinical features are here. In asymptomatic, you can see there is some periapical osteolytic lesion. There is a huge bone resorption. Okay. It is normal. And check the area, well surrounded area. So apisectomy sometimes is meant for such case. Apical true cysts are less likely to heal after non-surgical root therapy. They are self-sustained in nature, and surgical intervention is necessary. Sometimes we really have symptomatic apical periodontitis, but there is also condensing osteitis with it, chronic focal sclerosis osteomyelitis. And here we have to take care. Sometimes the persisting of such an irritant, it will cause reaction of bone formation. It will stimulate bone formation, and that might end up with chronic osteomyelitis, with proliferative periodontitis, because of the persistence of the pathogen. And really it is not well understood. In X-ray you can diagnose the case. If you take a parallel, if you take a periapical, there will be a very clear fracture line. I've seen one before 2 weeks. Unfortunately, she took the X-ray with her, and she came to my clinic asking for extraction of retained roots in the lower 8. and she was advised by a Turkish dentist who have done some implant for her on the 5 and the 4 region, and he told her to do extraction for the lower 8 so he can do an implant on the 7. So during x-ray, there was a swelling at the corner, and I asked her about that swelling. She said there was pain and she took a lot of antibiotics. On examination, on my examination for the palpation of the lymph nodes, I've noticed there is no lymph nodes. It's only pain in the angle of the mandible. I sent her to the x-ray. There was a very clear fracture line because of the persistence of infection, the persistence of the asymptomatic apical periodontitis. Okay, so it's end up to infection in the bone, and there was some resorption, and it ends to a very clear and clean fracture line. So it's generally believed that both lesions are caused by long-term low-grade inflammation or infection, or high resistance of local tissue to inflammation or infection, which means that the balance between the infection, between the toxin and the host was there with high resistance, so it's sustained for a long time. If the host was with low resistance, an abscess will be there. That's because the patient have a good resistance. There was some inflammatory changes in the bone. So instead of bone resorption, the inflammatory induced reactive bone formation of alveolar trabeculae, spongy bone around the periapex of the endodontically involved tooth. The case I've seen was not endodontically treated. It was just there were asymptomatic chronic inflammation left untreated in the lower one I've seen. Clinical outcome, how can I see it? How can I diagnose it? Mostly the lesion observes in young patients, and the mandible first molar is most common involved. The tooth often have gross carious lesion, can be vital or non-vital. There are usually asymptomatic. Radiographically, the lesion shows a well-defined or ill-defined radio-opaque mass associated with the apex. Lamina dura around the root apex is usually intact. Outcome, most of apical periodontitis lesion with reactive bone formation demonstrate healing after non-surgical root canal therapy, but if it's case of osteomyelitis, now refer to the surgeon. It needs a lot of work. The excessive compact bone in most cases will be remodeled for normal appearance. So till now we have explained the disease of the pulp, so whatever in the treatment in each case, and then we come to the case where the pulp was not treated, and because it's there in the pulp chamber, the pulp chamber is limited, does not allow the inflammation to extend, does not allow anything, so there will be a seepage through the periapical area, and we will have cases of acute symptomatic periodontitis that, if it is neglected, can be treated with root canal, a successful root canal. While if the root canal was not successive, it will, or the acute periapical periodontitis was already neglected, it will be end up to chronic, and that chronic, if the irritant was still there and the human defense mechanism get adapted to it, so it will end up to granuloma or chronic periodontitis. That chronic periodontitis, if it was still there with no treatment due to the definitely with the chronic, mostly I will have some sinus, so there will be drain of the abscess, and there is still toxins, still inflammatory response, but with low grade inflammatory response, then I should expect that some stimulation or bone formation will happen. Some changes or inflammatory change in the bone will happen. So I will end up to osteitis or osteomyelitis. Osteomyelitis mostly associated with fracture line is seen periapically, but if there is no fracture line, an occlusal x-ray can show some sequestration in the bone surrounding the teeth. So it's difficult to be diagnosed. Anyhow, hope to see you all in good health and wealth. See you next.